Hello, everyone, and thank you for coming to this presentation on a culture of safety, veterinary occupational health, and infection control. My name is Dr. Caitlin Macy, and I'm the District 9 Field Veterinarian with the Board of Animal Health. I am also leading the state's Veterinary Medical Reserve Corps, which is involved in training, developing, and deploying animal emergency response teams. Today's speaker is Dr. Jen Brown. Dr. Brown is the Indiana State Public Health Veterinarian. Dr. Brown has 16 years of public health experience at state, local, and federal agencies, and 3 years of clinical experience at a small animal hospital. She is board certified by the American College of Veterinary Preventative Medicine and is the immediate past president of the National Association of State Public Health Veterinarians. Her interests include zoonotic and vector-borne diseases, emerging infectious diseases, and animal-related injuries. So with that, we're going to have you take it away, Dr. Brown. Thank you so much for joining us.
Thank you for the introduction, and thanks to anyone who might have chosen to watch this webinar. We are going to talk about developing a culture of safety in your veterinary medical practices, but we're going to start with a case study of an investigation of potential zoonotic transmission of SARS-CoV-2 in a zoo setting, not only to pique your interest, but also to demonstrate why a culture of safety is so important. So beginning with our case study. So I'm going to talk to you today about a case study that took place in December of 2021. And at that time, what we knew about the potential for zoonotic transmission of SARS-CoV-2 is pretty similar to what we know now at the time of this recording in November of 2023. SARS-CoV-2 is primarily transmitted from person to person, and certainly the global pandemic was propagated by person-to-person transmission. However, human to animal transmission of SARS-CoV-2 has been well documented, and it's been well documented that big cats in zoologic collections have been disproportionately affected by human to animal transmission. On the other hand, animal to human transmission of SARS-CoV-2 has not been frequently reported. And at the time that this investigation took place, it hadn't been robustly documented in a zoo setting. So in December 2021, we at the State Health Department received reports of an African lion at an accredited Indiana zoo that had developed respiratory symptoms and subsequently tested positive for SARS-CoV-2 by a human rapid antigen detection test. Of course, this test was not validated for use in lions, but it was a good choice on the part of the veterinary team to go ahead and use this test in that context while they were waiting for diagnostic testing to be completed at an animal disease diagnostic laboratory. The lion was housed away from other susceptible animal species, and there were no other animals at the zoo that were reported as having symptoms potentially compatible with SARS-CoV-2. The zoo had been closed to the public since October 31st, which limited the lion's human contact only to designated zoo staff with key card access to the lion enclosure. And that was a key point that actually made it possible for us to do this investigation. If the zoo had been open to the public, I don't know that we would have been able to do this investigation because we would never have been able to rule out transmission from a member of the public. The zoo reported that they were following SARS-CoV-2 prevention measures that were developed by the Zoo and Aquarium All Hazards Partnership. This is a photo of the actual lion from this investigation. He was a 20-year-old intact male who had pretty severe physical limitations due to pre-existing medical issues. He had close human contact twice daily to receive medical treatments, and he had completed the series of an experimental SARS-CoV-2 vaccine for mink approximately 12 weeks prior to his illness onset, which occurred on December 18th. Unfortunately, he was euthanized 5 days after his onset of respiratory symptoms, but this was due to reasons unrelated to his SARS-CoV-2 infection. His pre-existing medical conditions included chronic renal insufficiency and intervertebral disc disease, and the reason he was getting twice daily treatments was to get laser therapy for his IVDD. And so his mobility was severely impaired, which for such a large animal made providing appropriate care for him and keeping him comfortable very difficult. He had been vaccinated on September 14th and October 7th with the Zoetis SARS-CoV-2 mink vaccine. He was positive for SARS-CoV-2 on December 18th, the date of onset of his illness, with a human rapid test. And then again, his euthanasia took place on December 23rd. So our first question was, well, have there been any symptomatic people? Because that might provide an explanation for the origin of the lion's infection. The zoo reported that at the time of onset of the lion's illness, all of the zoo employees were asymptomatic. And in fact, they called all of the zoo staff, including the people who didn't have regular contact with the lion, they called them in and had everybody get swabbed and tested with the same human rapid test by which the lion was positive. However, shortly after the lion's onset of illness, we received reports of ultimately 3 zoo employees who had developed symptoms after having had close contact with the lion. And so knowing that there was a potential for animal to human transmission, we agreed to initiate an investigation with the cooperation of the zoo. So throughout this presentation, I'll probably be using the term we to describe things that were done in the investigation. It certainly should not be implied that the Indiana Department of Health was the only agency that was participating in this investigation. In fact, this was certainly a multi-agency investigation that included cooperation, not just from us, but also the zoo, the State Board of Animal Health, the Animal Disease Diagnostic Laboratory, the Diagnostic Laboratory at USDA in Ames, Iowa, and our State Health Department lab. So there were a lot of participants in this investigation. When I say we, I'm kind of talking about everybody in the investigation. So starting to gather information about these human cases, we found out that all of them had been asymptomatic and had negative rapid tests on December 18th. And that 9 employees had had contact with the lion in the days just prior to his illness onset. And remember, people had to badge in and out of his enclosure. So we had a high level of confidence in this information. 3 of these employees developed respiratory symptoms, and all 3 tested positive with a rapid antigen test within 24 hours of their illness onset, and then subsequently went on to have their infections with SARS-CoV-2 confirmed by PCR. And then some of them had genetic sequencing. So we have 3 confirmed cases of COVID-19 in our human patients. So the objective for our investigation was to determine if lion to human transmission could have occurred. And so we had the following 2 questions that comprised our investigation. First, how was the lion exposed? Because if the lion was exposed via contact with another zoo employee, that person also could have been a source of infection for other employees at the zoo. And then second, and really the more important question from a scientific perspective was, did the lion infect other animals or people with SARS-CoV-2? So here are some of the methods that we used to answer these questions in the investigation. We performed genomic sequencing of our positive clinical samples from the lion and our positive human cases, and we compared those genomic sequences of the virus with sequences from 10 samples that were collected around the state of Indiana around the same time from human cases in the community. We reviewed available records for information about the nature of the interactions when people had contact with the lion. We also conducted employee interviews to gather information on their symptoms, their vaccine status, and their exposures. And using this information, we charted our symptomatic employees' likely exposure and infectious periods next to our lion case, which you'll see in a little bit here. We developed case definitions for both confirmed and probable cases. And I just want to point out that we're talking about confirmed and probable outbreak cases. All 3 human cases were confirmed cases of COVID-19, and the lion was the confirmed case of SARS-CoV-2. So when we talk about confirmed cases and probable cases, we're talking about our level of confidence that these cases were associated with a cluster of SARS-CoV-2 transmission in this zoo setting. So we defined a confirmed case as a human or animal at the zoo who had laboratory evidence for SARS-CoV-2 in a clinical specimen with a genomic sequence that was identical to the lion's viral genomic sequence. A probable case was a symptomatic human or animal who was positive for SARS-CoV-2 by PCR, but who didn't have a genomic sequence available. We also defined close contacts for our human cases as being within a proximity of 6 feet for 15 minutes or more in a 24-hour period. And we use this definition to define a close contact with the lion in addition to close contacts with other zoo employees. For the lion, we also defined cranial contact as a close contact where an employee was within arm's length of the lion's head. And we assumed that cranial contact with the lion would be higher risk than caudal contact, where the employee was about 9 feet from the lion's head. This was a really big intact male lion. And so hopefully you can see here that even though both of these zoo employees are having close contact with the lion, one of them at the cranial end is at much higher risk of exposure to his respiratory secretions. We made 2 assumptions in the investigation. One, that the exposure period was 1 to 10 days prior to illness onset, with peak transmission risk occurring between 3 and 5 days. And second, that the infectious period, or the time when the lion or infected people were contagious, began 2 days prior to illness onset and extended to 10 days after illness onset. This period was shortened for our lion case because he was euthanized fewer than 10 days after his illness onset. These assumptions are based on what we knew about SARS-CoV-2 transmission among humans at the time. These assumptions haven't really been validated for lions, but this was the information we had. So we decided to apply the same logic to the lion that, that public health guidelines had been applying to human settings. So as I told you before, we charted our lion and our human cases using our developed definitions and assumptions. And in this figure, what you're looking at is a timeline for each of our 4 cases, our lion case on the top, and then our 3 human cases, which we are calling Z1, Z2, and Z3. The blue bar, or the left-hand side of the bar, for each of these timelines is the exposure period. So this is the time period when we assumed that that patient's exposure to the virus occurred. And the red side of the bar, or the right-hand side of the bar, is the infectious period. So this is the period where we assumed that this patient was potentially contagious or a potential source of infection to others who were exposed. The red triangle is the illness onset date for all 4 of our patients. And then the yellow circles are describing the points in time when each of our human employees had contact with the lion during their potential exposure periods. So you can see a couple things here. We can already draw a couple of conclusions just by looking at this chart. So during the lion's infectious period, you can see that Z1 and Z2 each had a single day of cranial contact. Well, actually, we have not marked here which was cranial and which was caudal contact, but Z1 and Z2 both had at least 1 day of cranial contact during the lion's infectious period. And Z3 had cranial contact with the lion on 3 occasions during their infectious period. So I want to point out that there's a lack of overlap between the infectious period for Z1 and Z2 and Z3 and the lion's exposure period. So for all 3 of these human cases, the period of time when we expect them to be contagious is after and does not overlap with the period of time when we assumed that the lion was exposed. So in other words, all 3 of these human employees had onset of illness after the lion. And so based on what we know about the virus, we ruled out all 3 of these employees as potential sources of infection for the lion. We decided these Z1, Z2, and Z3 were not the people who could possibly have transmitted the virus to the lion. You can also see that Z1 and Z2 had onset of illness on the same day, and we interpreted that to mean that neither of them could have been the source of infection for the other. And there's a lack of overlap between Z3's infectious period and Z1 and Z2's exposure period. So Z3 could not have been the one that infected Z1 or Z2 because Z3's onset came after theirs. So just charting it out this way, we were able to draw some initial conclusions. And this doesn't prove anything, of course, but this is consistent with a potential hypothesis of lion to human transmission. So taking a look at this made us want to dive deeper into the investigation. We'll talk a little bit about the genomic sequencing part of the investigation. So we used a phylogenetic tree to visualize the relatedness of the genomic sequences of the samples. So you don't need to be a geneticist to interpret this tree. Basically, every dot that you see here represents a different genomic sequence of SARS-CoV-2 that was obtained from a clinical specimen. And I'll walk you through which clinical specimens are which, but basically the closer together on this diagram the dots are, the more closely related the genetic sequence of the SARS-CoV-2 that gave rise to these patients' infections. So the one that I've circled here in the lower right-hand corner is a clinical viral genomic sequence from a clinical specimen obtained from the lion on the date of onset of his illness. And then D5 is a clinical specimen from the lion on the 5th day post-onset, which I think this was probably a necropsy specimen, unfortunately. So we have 2 specimens from the lion. And then we have genomic sequences from Z1 and Z2, 2 of our 3 symptomatic and positive human employees. And these dots, you see how they're all on the same line? That all of these genomic sequences from these clinical specimens were exactly the same. They were identical. And it's actually kind of unusual to see them being perfectly identical. It's not that unusual to see some small, tiny differences in the genomic sequence. And you say, well, that one's close enough. We're going to call those closely related. But these had no differences. They were exactly the same sequence. It was the same virus. So this means that Z1 and Z2 are confirmed outbreak cases. This does not prove the direction of transmission. It just means that Z1, Z2, and our lion were infected in a common setting, and it decreases the possibility that Z1 or Z2 acquired their infection from some other source, and it was just a coincidence, if that makes sense. Z3 was positive by PCR, but the quality of the specimen was not good enough to be sequenced. So unfortunately, we don't have a genomic sequence for Z3. So Z3 is a probable outbreak case. PCR positive, infected in a common setting, but could not be sequenced. So the rest of these dots are viral genomic sequences taken from 10 different clinical specimens from patients in 7 Indiana counties, collected from August 2021 through February 2022. The ones that are starred were collected in December 2021. So they were collected at the closest period in time to when our little cluster occurred. You can see that the one marked S6 is probably most closely related to our outbreak strain, but it is not identical. I mean, we would not consider that to be the same as the outbreak strain. So basically what we conclude from that is that this genomic information is consistent common setting that was not related to community transmission is what we take from this. It does not prove that the lion gave it to the people, but it is consistent with our hypothesis. So our next question is, okay, well, how did the lion get exposed? Because you'll recall that all of our employees were asymptomatic and negative by rapid test on the date of his onset of illness. So we did a traceback review of the data to identify potential sources. There were no visitors or other animals near the lion's enclosure during the lion's exposure period, and so we eliminated these possibilities as possible sources of infection for the lion. 9 employees entered the lion building at least once during the lion's exposure period. And recall that we excluded our 3 human patients as being the source of infection for the lion because the timing was not right. They had onset of illness and were contagious after he became symptomatic. So that left 6 candidate human sources for the lion's infection. We took a look at who had cranial contact with the lion within the 5 days prior to his illness onset. And there was 1 person with cranial contact, and this is who we just called Z5 in our investigation. However, you couldn't rule out any of the other 5 as possible sources of exposure. We concluded from this that Z5 was the most likely source of infection, but you can't rule out the possibility that it was actually one of the other 5 employees instead. There's no additional information we could collect to sort this out further. We're just never going to know who it actually was, but we think it was probably Z5. So the next part of our investigation is to determine whether the lion infected other animals or people with SARS-CoV-2. So again, we knew that no visitors were exposed because the zoo is closed, and no animals became ill because the zoo was monitoring that very carefully. So the lion did not transmit SARS-CoV-2 to any of those groups of people or animals. Reviewing the data, we knew that 8 employees entered the enclosure during the lion's infectious period, so 2 days prior to onset up until the date of his euthanasia. 3 of them subsequently developed COVID-19. 2 were confirmed outbreak cases, Z1 and Z2, and 1 was a probable case, Z3. So we had 3 different possible scenarios for our human case's source of infection. In scenario 1, we looked to see if any of our cases had close contact with the lion's probable source, so Z5. The answer was no. So then we asked if any cases had contact with the 5 possible lion sources. That was Z4, Z6, Z7, Z8, and Z9. And 1 person did, but the other 2 did not. So we concluded from this that it was possible that Z1 acquired infection from Z5. This could not be ruled out. In scenario 2, we looked at possible community sources for our human cases. None of our cases had known contact with COVID-19. So nobody reported, oh, hey, someone told me that they were infected and after I was exposed to them. Nobody reported anything like that. But Z3 did report quite a lot of activity in the community, going to social events. This was December, it was the holidays. So Z3 was out there in the community quite a bit, potentially getting exposed to infected people. Z1 and Z2 reported that they were not doing those activities. So for Z3, we couldn't rule out the possibility that they had acquired their infection from a community source. And in scenario 3, we looked at the possibility of the lion being the common source for all 3 infections. All 3 employees had close contact with the lion within 5 days of their illness onset, and Z1 and Z2 had identical sequence to the lions, which was compelling evidence that the lion was probably the source for their infection. Z3 sample was unavailable for sequencing, so we concluded that the lion was a possible source. So this analysis doesn't prove that the lion infected these 3 people. However, infection from the lion is the only thing that would explain infections. So while we can't rule out the possibility of staph exposure for Z1 and community exposure for Z3, all 3 human infections could be explained by lion exposure. And so we are calling this probable lion to human transmission. We will never know for sure if that's what happened, but we think it is the most likely explanation for these 3 human cases. And this is a graphic of what I just said. So our conclusions from this investigation is that an asymptomatic zoo employee carrying SARS-CoV-2, probably Z5, but we will never know, was the source of infection for the lion, who then went on to infect 3 other human zoo employees. We have Z1 and Z2, we have a higher level of confidence, and probably Z3, although no genomic sequence was available. So how did this happen? We know from everything we learned during the pandemic that coronaviruses most commonly spread between people who are in close contact about 6 feet apart, and that coronaviruses are primarily spread through inhalation of infected respiratory droplets. However, we also know that coronaviruses can be spread through surfaces contaminated with infected respiratory droplets. You'll also know this as fomites, doorknobs. It could be medical instrumentation. It could be an exam table, and on and on. And we also know from the pandemic that SARS-CoV-2 can be spread through inhalation of infected airborne particles. So I love this picture, and thank goodness for this guy being willing to have such an unflattering photo be taken of himself, because I think it's really instructive. If you look at this photo, you can actually see the larger droplets of respiratory material scattering down from this respiratory plume. And you can see how those larger droplets are going to hit the ground well within 6 feet of this gentleman's sneeze. But then you can see sort of in the center and up towards the upper right-hand corner of this photo, there's a finer, there's some mist-like particles that are much finer and more difficult to distinguish from one another. And they're smaller, and they probably have a bit more loft to them, and might travel a bit of a further distance. So when we talk about staying 6 feet apart from each other during the pandemic, this was the type of transmission that we're trying to avoid. And certainly when we mask up, it decreases further the distance that these respiratory droplets are able to travel. This is just a cartoon kind of showing you the same thing. So you see the larger respiratory particles, these are droplets, are drifting down towards the ground. And the smaller respiratory particles are less than 5 microns in diameter. This is way, way, way smaller than the diameter of a human hair. They can travel a further distance. So this is how this is how transmission occurred in this setting. And we also know from the pandemic that asymptomatic people can still be potential sources of infection for others, especially when they're in close contact with other susceptible individuals. So we concluded from this, lion to human transmission probably occurred. This had never been robustly documented in a zoo setting. There had been some other cases where it was thought to have happened, but the unique epidemiologic circumstances that we had allowed us to demonstrate a bit more conclusively that that's probably what happened. And we conclude from this that zoo employees have an occupational risk for SARS-CoV-2 infection, regardless of their vaccination status. Zoo employees who have close contact with animals that are susceptible to SARS-CoV-2 should take precautions to prevent outbreaks. This is an important lesson that emerging infectious diseases, many of them have a zoonotic potential, and which means that in a veterinary medical setting, our employees can be exposed to novel hazards, and we don't always know the best way to protect our employees from those hazards. But the good news is there are precautions that can be taken to improve veterinary infection control and to improve occupational health for your employees. That's good medicine, and it's the right thing to do as an employer. I'm going to talk to you a little bit about some of those resources in the second part of our webinar. So this is a question that everybody probably has on their mind. It seems like one thing just happens after another, right? First it was First it was SARS-CoV-2, and then, over the last few years, there's been a lot of discussion about Ebola. What should we do with pets of people who've been exposed to Ebola? We've had an animal epidemic of highly pathogenic avian influenza for the last couple years. There was an Mpox outbreak that's occurred over the last couple years. What's the implications of that for animal health? So it just seems like every year there's a new novel emerging pathogen that we didn't know about before. Even right now, there's an epidemic of respiratory infection among dogs for which we don't have a diagnosis. So how can we be prepared if we don't know what's coming next? We don't know what the next thing is going to be that we need to be worried about. How can we possibly prepare? Well, the answer is you can't. I don't know what the next thing is going to be. And if you would have told me a couple years ago that there would be an outbreak of this coronavirus and that one day we would be able to identify lion to human transmission in a zoo, I would never have believed you. I could not have possibly anticipated that exposure situation or risk. But the good news is you can implement occupational safety and infection control policies that are universally effective against a wide variety of known and emerging pathogens. And as I said, this is good for your employees. It's the right thing to do as an employer, and it's good medicine for your patients as well. So why is this important? Why is it important to have an infection control and safety program? It's not enough to really think and talk about infection control. What's really important for your medical practices is going to be to have a plan, to have SOPs and policies in place that standardized policies that people can follow. It's important for animal health. It is good for biosecurity, decreases the opportunity to spread diseases from one facility or animal to another. It decreases your risk and risk for your employees of getting sick. And it's your responsibility because we know that this is an issue. And so we need to do whatever we can to be prepared. We have this issue of multi-drug resistance. So antibiotics that we count on to treat our patients and that human practitioners count on to treat human patients are becoming resistant and less effective. And this makes it more important to try to prevent them at the transmission level rather than trying to treat them once an infection has occurred. People are developing closer relationships with their pets, and we also have better molecular detection methods and technology, which means when things happen, we're going to be able to figure out what's going on more than we could in the past. Hospital-acquired infections, these are a really big deal in human medicine. Nosocomial infections is the other term that you might remember from school. So we in veterinary medicine are doing more specialized procedures. We're doing more advanced procedures. We're doing procedures with higher risk. In some cases, our clients are tolerating that higher risk and maybe higher expense. And this means longer stays in the hospital, which increases the possibility of a hospital-acquired infection. So in human medicine, 5 to 10% of patients who are admitted to a hospital are going to be diagnosed with a hospital-acquired infection. This is bad for the patient, and it's bad for hospital operations and for staff morale. I mean, nobody wants to think that the patient they're trying to help got sick while in their care. And so this is increasingly going to be a recognized problem in veterinary care that we want to be prepared for. Our staff, the people who make it possible for us to do our jobs, are exposed to unique hazards every day as part of their daily work. These could be chemical hazards, biological hazards, physical hazards, and mental health hazards. The consequences of these hazards range from minor to severe or even fatal. And our staff have exposure risks that people with office jobs don't have. So there's a lot of different hazards that we need to be on top of and be aware of and try to prevent. So talking a little bit about the modes of transmission, we can't prevent disease transmission unless we recall the different ways that it's transmitted. So there's direct contact with tissues, secretions, bites, scratches, petting, touching, doing a physical exam, doing procedures, drawing blood. direct contact, physical contact with an animal is an important means of transmission for some pathogens. There's indirect transmission. This is the fomites we were talking about. This is an intermediate inanimate carrier that can pass the pathogen from one host to another via contaminated surfaces. This could be an exam table. It could be a truck. It could be your stethoscope. It could be a kennel or a cage in your ward. We have oral transmission, ingestion, eating or drinking contaminated water, licking or chewing contaminated objects or surfaces. And then we have, I love this picture because it's basically the exact same picture as the man that was sneezing. But this is a cow sneezing instead, and you can see that exact same respiratory plume is generated. Droplets and airborne particles both comprise that respiratory plume. And then this one's near and dear to my heart. We have vector-borne transmission via arthropods like mosquitoes, fleas, ticks, roaches, and other bugs. So here's a couple of things to remember. Every animal admitted to your facility, whether or not they appear healthy, can be an asymptomatic or colonized shedder. I mean, remember Z5 in our investigation was a perfectly healthy asymptomatic person who was the probable source of infection for our lion. So even if everyone seems healthy, you're not, you can't assume that no risk is present. There's always a risk for the introduction and spread of zoonotic pathogens or potentially hospital-acquired infections. And I love this graphic, and it applies to so many different things. But this is the hierarchy of controls. This is a cartoon from NIOSH, which is CDC's division that focuses on occupational health. And if you think of any hazard, like SARS-CoV-2, there's a hierarchy of controls that we could rank from most effective in preventing the hazard to least effective to preventing the hazard. So think about SARS-CoV-2, elimination of the hazard. That would be like telling someone who's sick not to come to work. The hazard is not present in the workplace if the sick person is not there. That's an administrative level policy to keep the hazard out of the workplace. Substitution or replacement of the hazard isn't really very applicable for SARS-CoV-2. Then we have engineering controls, isolate people from the hazard. So this would be like if someone gets sick at work, then they're going to isolate themselves until they go home. Or maybe you have someone who's like, well, I'm not feeling good. I'm going to work in my office with the door closed for the rest of the day. That's better than having them continue to have contact with people, but the hazard is still present in the workplace. It's not the same as sending them home. Administrative controls are things like changing the way that people work, changing people's practices about cleaning and disinfection, requiring people to wear masks at work if we're having a pandemic and things like that. And then the last one is PPE. And so these are ranked from top to bottom, most effective to least effective. So you see a person wearing PPE to protect themselves against SARS-CoV-2 infection is actually the least effective means of control. It is much more effective to have a workplace policy that someone who's sick doesn't come to work. That's way better than having a sick person come to work and having everyone wear masks. But I feel like a lot of our discussion and focus often is here at the bottom of this hierarchy. We talk a lot about PPE when that's actually the least effective means of control. And this is not just true for SARS-CoV-2, it's true for many, many, many other things. So I want to encourage you, when you're thinking about your workplace infection control policies, make sure you're not spending all your time down here at the PPE level. PPE, of course, is very, very important. It is a very, very important component of keeping our employees safe. But it's not the only thing we should be thinking about, because there's a lot more effective measures that could be taken that would offer more layers of protection. So we have these basic levels of precautions, And you could think of these as veterinary standard precautions. These are modeled after the human standard precautions guidelines, or human guidelines for infection control, I should say. So standard precautions would be washing your hands or using alcohol-based hand wash or rub before or and after any patient contact, and wearing gloves as appropriate. Contact precautions means you are trying to put a barrier between yourself and the potential source of infection, your patient. So gloves, maybe a waterproof gown, protection of your mucous membranes like your eyes or mouth, and then you're still going to wash your hands before and after patient contact. And then isolation precautions are the whole 9 yards: gloves, waterproof gown and coveralls, shoe covers, rubber boots, hair cover, foot baths. You're going to restrict the number of personnel interacting with this patient, wash hands, potentially change clothing if it gets contaminated, and then maybe house the patient in a different room with negative pressure ventilation. So you can see these different levels of precautions for infection control. Hand hygiene is really one of the most important components of veterinary infection control. You saw it was a key element of each of those precaution levels on the previous slide. It reduces the bacteria on your hands. The goal is to remove or reduce these transient bacteria to prevent rebound growth. When you wash your hands, you're not rendering them sterile. You're still going to have bacteria on your hands. Your goal is to drastically reduce the amount of bacteria that you're transferring from your hands to other patients. The use of gloves doesn't provide complete protection. You can't put on gloves and think that that obviates the need for you to wash your hands, because donning and doffing gloves can contaminate surfaces as well. So everyone who's at your facility should have education and training and constant reinforcement regarding hand hygiene. At human hospitals, there are people, infection control practitioners, this is a key component of their job, is going around the hospital and making observations on how well people are complying with hand hygiene, and in order to reduce hospital-acquired infections. I'm not saying that you guys need to do that in your veterinary practices, but I tell you that to call attention to the priority given to hand hygiene in human hospitals because of the problem with hospital-acquired infections. Hand sanitizer does not work in the presence of organic material. So if your hands are contaminated with respiratory secretions or stool or any other infectious material, you cannot expect that putting hand sanitizer on top of that material is going to be very effective in reducing bacteria in that environment. It's also really not very effective against protozoan parasites and non-enveloped viruses. Does hand sanitizer have its place though? Absolutely. If you don't have access to soap and water to do hand washing, then hand sanitizer is better than not doing anything. And having hand sanitizer available may improve compliance with a hand hygiene protocol. If you're in an environment where you don't have soap and water, moist wipes and hand sanitizer are an acceptable substitute until you can get to a hand washing station. So personal protective equipment, we've talked about that. It's clothing or equipment you just wear to protect yourself from infection or injury. It prevents contact with an infectious agent or body fluid that might contain an infectious agent by creating a barrier. We wear PPE every day. We wear scrubs, we wear lab coats, we wear closed-toe footwear. You could think of other everyday items as PPE. We carry umbrellas to protect ourselves from the rain. So we just need to remember to change, remove, and disinfect these items before we go home, because we don't want to contaminate our regular clothing with contaminated PPE. So you got to think about all the parts of your body as well as all of the modes of disease transmission. We have direct contact, we have ingestion, we have indirect contact, respiratory contact. So gloves protect your hands. They provide a barrier for your skin. Gowns and coveralls are going to protect your skin and your clothing. Masks protect your mouth and your nose from mucous membrane exposure or ingestion or respiratory inhalation. Goggles protect your eyes. Face shields, face, mouth, nose, and eyes. Boots and bonnet. So you just want to think about getting all the parts of your body covered and with attention to what pathogen you're trying to prevent. And this is a great reference. So this is infection prevention and control best practices for small animal veterinary clinics. This is just a snippet of what's located in this document, but this is going to give you some ideas. If you have a patient presenting with a certain combination of symptoms, this is primarily focused here on small animal, but it's going to give you an idea of what infectious agents could be responsible, what's the name of the disease produced by those infectious agents, highlighting those that have a zoonotic disease risk, and then giving recommendations for PPE, which is great. Take some of the guesswork out of it. So when we talk about respiratory protection, we've all heard a lot about N95s with the COVID-19 pandemic, and N95s are the best form of respiratory protection for certain pathogens. However, if you're an employer and you want your employees to use N95 respirators as respiratory protection, OSHA does require you to have a respiratory protection standard. And the reason why is because N95 respirators, you can't just grab one and slap it on and expect that it's always going to be effective without properly fitting it to that person's face. And also, some employees may have some medical conditions that might make it difficult or even hazardous for them to wear an N95 respirator. So if you want to include N95 respirators in the PPE options that you offer your employees, you're not compliant with OSHA unless you are following these regulations. And so what's included in this is you have to have written procedures for N95 use. You have to have a plan for surveillance of the work area when N95 respirators are being worn to ensure compliance. You have to have an air quality standard plan. You have to have a program evaluation plan. And each employee that is approved to wear a respirator has to undergo a basic medical evaluation, a basic training, has to have an initial fit test, and then an annual fit test. And this is actually really important. I've been through this fit testing process a few times, and there's all different kinds of N95 respirators. Everybody's face has a different shape, and not all of the respirators are going to fit properly on your face shape. And if it doesn't fit properly, then it's actually not fully doing its job of protecting you, because if air is getting in gaps between the respirator and your face, then it's not working properly. So that annual fit testing was waived during the COVID-19 pandemic. I actually don't know if that requirement has been restored, but I just want to tell you guys a few details about what's necessary to get onboarded with respiratory fit testing. I will back up and say, I don't know any veterinary practice that has this. And we talked a lot with CDC about when they were creating guidelines for veterinarians for examining animals that might have SARS-CoV-2 infection. They were saying, well, everyone should wear an N95 respirator, and the state public health vets, we're talking with them about how unlikely it was that that this was in common practice in veterinary clinics. So if you don't have a respiratory protection program at your clinic, and you don't have employees that are fit tested for N95 respirators, then the next best thing would be to wear a surgical mask covering your nose and mouth, and wear it, pretty snugly, and then wear goggles or a face shield to provide some additional protection. Or actually, a face shield with a mask would be the best protection, because it would present a barrier over your entire face. Not as good as an N95 respirator, but better than not having that additional level of protection. So disinfectants should be picked to meet the needs of your facility. There's no one size fits all, and you guys all know that different disinfectants are appropriate for different pathogens. The Center for Food Security and Public Health at Iowa State University has some great resources on disinfectants. It'll tell you what types of pathogens they're effective against, their contact time, how they should be appropriately used. So I encourage you guys to look at some of these resources. So again, talking about organic material, you can't expect cleaning and disinfection to be effective in the presence of visible organic material. So, whoops, if a surface is heavily soiled, just clean it with soap and water first, and render it an apparently clean surface, and then apply your disinfectant. It'll be much more effective. And then make sure it sits for the appropriate contact time. We all know how um, the exam room table cleaning goes, sort of grab the bottle, squirt, squirt, swipe, swipe, and then you're ready for the next pet. But that is not really letting the disinfectant do its job. So other elements of your program to think about, your workplace policies. Remember, we talked about that hierarchy of controls. Things like paid sick leave, offering employees vaccination against rabies, and making accommodations for pregnant and immune compromised personnel can be incredibly effective methods to prevent your employees from being exposed to or impacted by hazards. Injury prevention, like ensuring that people are not restraining animals until they have been properly trained on how to do so effectively, and putting measures in place to prevent needle sticks. And environmental controls like isolating animals with infectious diseases, giving some attention to how you handle potentially contaminated laundry or waste, and giving attention to rodent and vector control are all going to be important components of your infection control plan. So infection control culture. So this is a little promo graphic from Hills. You know you're a vet when you have a sandwich in one hand and a stool sample in the other, and you think nothing of it. And I mean, this resonated with me. I worked in a small animal practice, both as an assistant and as a vet. And I I think that, this may be funny, but I think it also reflects a casual attitude in our profession at large, with regard to infection control, and with regard to blood, feces, and body fluids. And that casual attitude is increasing the risk that we and our employees may be exposed to zoonotic pathogens. So I would love to see us change from this sort of attitude of holding that sandwich in one hand and stool sample in the other, or similar types of activities, and laughing about how crazy it is to be in the veterinary medical profession. I would love to see us move away from that and move to a culture of safety. I would love to see a culture of safety in our profession that is so strong that Hills would never think of making a promo ad like this, because that is really reflecting how much we value each other and how much we value our employees, if we prioritize their safety. So that you guys have a lot of resources available to you. The one I want to highlight is the Compendium of Veterinary Standard Precautions for Zoonotic Disease Prevention. This is maintained by my organization, the National Association of State Public Health Veterinarians. And the last edition was 2015. It is in the process of being actively updated, and the update's going to cover things like SARS-CoV-2 and Ebola and stuff like that. But it's a great start. And along with this, there's a toolkit that includes a model veterinary infection control plan to help give you some ideas for how to create a plan like this for your practice. Oh, here it is. This document has been endorsed by AVMA and AHA. And it's not just for small animal practices. I just want to say, these principles of infection control apply to large animal and ambulatory and food animal medicine just as much as they do to small animal medicine. The plan's just going to look different because the working environment is different, but the principles of infection control are the same. So my take-home messages for you, emerging infectious diseases can be transmitted from animals to humans and from humans to animals. And we don't know what the next one's going to be and what the implications are going to be for veterinary medicine. The zoonotic potential of many infectious diseases is unknown. Even infectious diseases we already know about are manifesting in new ways, new modes of transmission in new populations all the time. Our public health recommendations usually err on the side of caution, especially in a situation where the risk is unknown. And that sometimes means that the public health recommendations are going to be, kind of unrealistic. So I would love to encourage you all to not wait for us to give you recommendations from the public health level, but to proactively establish and implement policies in your own practice so you can be ready for anything. And policies that are designed to prevent and control the spread of infection from animal to animal, or from animals to people, or from people to animals, are going to protect your patients and they're going to protect your staff. So it's good medicine and is creating an environment of better occupational health for your staff. I put this presentation together with help from a lot of people, people who worked on the zoo investigation, and also people who gave me some veterinary infection control slides. So I want to thank everyone who helped me put this together. If you want to read the peer-reviewed article reporting the probable transmission of SARS-CoV-2 from the lion to zoo employees in our state, you can grab a screen grab of this citation here. And if you don't have access to, actually, this is a free access publication. So I believe you ought to be able to download this article without having to go through a paywall or have a subscription or anything like that. So you should be able to download that for free. And if you have any questions about veterinary infection control or zoonotic disease or a specific patient or any problem that you're having, I would love for you to call me. I'm the State Public Health Veterinarian, so I work at the Indiana Department of Health, but I work really closely with my good friends at the State Board of Animal Health. So if you have any questions related to human health, I would love to speak with you. You can call us. This is our main number for our agency, and you can also email me at the email shown here. So I would direct any questions to this phone number or to this email address. I wish you all the best, and I believe there should be some accompanying instructions about how to get continuing education credit from viewing this webinar. Thank you so much.